I am Valentin Fuster from New York, and again, we are all together to discuss what went on in this meeting. We are in New Orleans, American College of Cardiology. There's a lot of things to discuss, and as usual, we have an outstanding group of colleagues here who they are going to talk short. Otherwise, I will clip them. I will clip their mouths, which is the third study that we will discuss today, the clipping of the mitral valve. Anyway, a lot has been going on. Many of us keep talking about molecular biology, genetics, but I can tell you the plumbers are really there. We have a number of studies that have been presented in this meeting. The partner study, the clipping of the mitral valve, bypass surgery in patients with significant cardiac failure, and so forth. So we are not going to be talking about molecules today. We are going to be talking about devices, and we have a number of experts here. Let me introduce my colleagues. From the right, Dr. Neil Moat is Director of Transcatheter Heart Valve Program. He's a cardiac surgeon at the Royal Brompton Hospital in London. Dr. Laura Mauri has been very involved with the mitral valve clipping. He's Assistant Professor of Medicine at Harvard Medical School, interventional cardiologist and Director of Biometrics at the Brigham and Women's Hospital in Boston. Again, Bob Harrington, I think we have to give you a rest. Anyway, welcome back, though.
Thank you.
Richard Sinstack, Distinguished Professor, Division of Cardiology, Director of the Duke Clinical Research Institute in Durham, North Carolina. There, far in the left, we have Dr. Clyde Yancy, past President of the American Heart Association. He found a new home in Chicago, and he's now the Magistrate Professor of Medicine, Chief of Cardiology at Northwestern University in Chicago. Congratulations.
Thank you, Bill.
And here on the left is another usual, Dr. Harlan Krumholz, Harold Hines Professor of Medicine, Cardiology, and Professor of Investigative Medicine and of Public Health at Yale University. Before this meeting, he was going up and down, and talking, says, just keep quiet, your catecholamines are rushing too much. We'll see. And here on the left, we have Dr. David Kandzari, Director of Interventional Cardiology and Interventional Cardiology Research at Piedmont Heart Institute in Atlanta, Georgia. An outstanding group of people. I think there is discussion for everybody. And what we are going to do, we will begin discussing the partners trial from the point of view of intervention to transcatheter aortic valve replacement versus surgical valve replacement, and then we'll talk a little bit about the economics. And then we will move into the percutaneous repair of the mitral valve, and we will move again into the STICH trial, which we discussed last year, but today is in a different context. So we have 1 hour, and we have to do all what I said. Let me begin by the partners trial. You probably recall it was about a year ago that Dr. Marty Leon presented at this meeting the results of an investigation that involved patients treated with transcatheter aortic valve replacement. They were very sick. In fact, they were not eligible for surgery. And these patients were compared with another group with medical therapy. And the results were actually outstanding. If I recall, it was about a 50% decrease in mortality, cardiovascular mortality, or very close to it, and certainly a significant improvement in the quality of life. So these were very sick patients. Today, we have sick patients too, but they are eligible for surgery. This is the partners cohort A. The principal investigator, Dr. Craig Smith from Columbia University, who presented the study. And I will, just before the discussion, maybe I will give a summary of what the study was about. in fact involved near 700 elderly patients, median age of 44 years, with severe aortic stenosis that were randomized to either TAVI, the transapical procedure in a group of patients, and transfemoral in others, almost half and half. And these patients were collected in the United States, Canada, and Germany. And there was a randomization, as I mentioned, between the non-surgical intervention and the surgical intervention. And these patients were now followed for approximately 1 year, and the results actually are quite interesting. This is a very sick population, and therefore there is always concern about how they are going to do in terms of mortality. Well, it turns out that this was a non-inferiority trial and fulfilled the rules of non-inferiority. At about 1 year of follow-up, the primary endpoint, which was actually mortality, was 24% in the TAVI group versus 26% in the surgical group. This, in one hand, I think is an outstanding kind of achievement, since this is a very sick population. On the other hand, obviously, we are dealing with a high mortality over a period of 1 year. In terms of aspects that we will discuss, one of the most important ones is stroke, and that is the stroke incidence was 8% in the TAVI group versus 4% in the surgical group. And this is of some concern. This is actually the combination of stroke and TIA. And there were other aspects that we will discuss: the need for pacemakers, vascular complications, valvular insufficiency. We will discuss these. But basically, we have a study of a population that is very sick, and it shows that at least we have a technique, the transcatheter aortic valve replacement, which is quite feasible, and with the results being quite remarkable. Robert, maybe you can give a sense of what is your reaction to the study.
It's similar to my reaction when I saw the results of the cohort B. I mean, this is game-changing. This tells us that it is possible to treat severe valvular disease percutaneously. But I'm going to put a big if on that, that maybe we can come back to. One of the things that impressed me most at the presentation yesterday was not actually the presentation. It was the lead-in to the presentation, which was a case from the Cleveland Clinic, where they took us through the various steps of considering what you needed to offer this to a patient. You need world-class clinicians. You need world-class echo. You need world-class CT angiography. You need highly experienced interventional. You need highly experienced surgery.
And a good budget to start with.
And a good budget to put this all together. So it may be a topic we come back to.
Yeah, we will.
I think from the medical perspective, fantastic. But we need to think about these other issues.
Neil, you are very close to the field.
Yeah, I think, as with Robert, I think it was a very interesting presentation and very exciting data. I think it's good news for the patients, because there is an option there to treat these patients either with TAVI or by conventional surgery. And I think that still the decision needs to be tailored to the individual patient. The trial clearly met its non-inferiority grounds, but actually there was a trend for certainly the early mortality to be less in the TAVI group. ITU stay was lower, and a suggestion that there was a faster recovery. If one looked at quality of life at 30 days, that was greater in the TAVI group than surgery. I think that's quite important to these elderly patients, that they are able to get out of hospital quickly, get back into the community, and certainly that's our clinical experience, is that we can get the patients, these high-risk patients, through with surgery, but it takes a long time for them to get back into the community. So as well as mortality, I think that rapidity of early recovery. The big but in the trial I have is the stroke risk. Not only is the stroke risk higher earlier, but there appears to be an ongoing stroke risk over the first year in the TAVI patients that seems to be higher than that seen in the AVR patients. And I think that's one of the big questions that the trial brings up.
Yes, Laura, there were a number of complications, vascular complications, as with the very thick catheters, as one can expect. There's a number of pacemakers. Actually, a study was presented today, which was not the same cohort, but from Canada, with I think is an 8% or 9% need for a pacemaker. And then I like to touch into valvular insufficiency. Why I'm talking about these problems? Because we will have a tendency very quickly to go into younger people, less sick people, which I think is obvious. But on the other hand, we have to really pay attention to the problem. So what's your opinion of the trial and of the complications?
Well, if you take a step back and you think about who was enrolled in this trial, it's important to be cognizant. Even though these were operable patients, they were high-risk operable patients. And a surgeon and a cardiologist had to review the patient. They were reviewed with the larger board that were managing the trial as well to make sure these patients were both appropriate for either of the procedures, but also that they were high enough risk to be included in the trial to begin with. So they had to meet an STS score of at least 12% or have a predicted operative mortality of at least 15%. So these are really very sick patients. So it would not be appropriate, I think, to your question of whether this is ready for the routine practice and use in aortic stenosis, but rather this is the first following after the non-operative patients, the first use of the device in surgical patients. So it's a narrow group of patients for what we see being treated right now. Now, I think from the standpoint of the balance of all these different risks, certainly we know with the percutaneous procedure, the treatment of AS did not achieve the same reduction in gradient or the same increase in aortic valve area, and was associated with higher aortic insufficiency, as you mentioned. That being said, these are patients with high mortality, and we may be very happy to have a procedure that is less invasive and associated with equivalent one-year outcomes. I'll be very interested to see the longer-term follow-up as well, because these are patients who have an ongoing risk of mortality, and that may be an important distinction between the two treatments in the future.
Harlan, the primary endpoint was mortality. Now, in the first year, the mortality was high, as Laura mentioned, very sick population. Now, it was the so-called cost-effective approach to these, and actually to this particular trial, but not the surgical versus the non-surgical group. This was going back to the study presented last year of the medically treated patients versus the patients treated by this procedure. And the economics are interesting. In a way, is $80,000 more of the cost of treating these patients with such transcatheter procedure than medical therapy. And when this goes down into per life year gain is about $50,000. Now, this is going to be an epidemic because people are getting older and the procedures are going to get in. But how long we prolong the life of these people? This is really my question to you. Certainly is very significant, the non-inferiority, but you are really offering procedures to people that I'm not sure how long are going to last. And I'm just presenting this on an economic basis.
Well, I think there are two issues. The earlier study took people who had no option. They were being refused for surgery. And, I mean, I think we all have had the experience of those patients who are just seeking some way to live. And if you can palliate with this device, it seemed in the study that many of them were able to improve their functional status quite substantially. And I think the challenge for us is to figure out how to deliver these kind of treatments in ways that are as efficient as possible, making sure we're identifying the people who are most likely to gain benefit and work harder to try to figure out who's likely not going to benefit and avoid it. In this one, which compares it with surgery, it's a very different group. And in fact, we don't even know exactly what, these patients were going to do poorly, but we don't know how this is going to play out in practice, because you've got a durable procedure that we know is tried and true. And now as you've suggested, as you start putting that out, we're going to need to see what happens, and then also what happens long term. So I think thinking about the economics in this trial is going to be a lot more complicated. In the other one, This is almost just figuring out how can you palliate someone who's sort of at the end of the life and very high mortality. Even with the device, that group had experienced very high mortality, and I think in that case, it's going to extend us. I just want to go back to Bob's question. I heard a lot about Landmark trial. I heard somebody say it was the most amazing thing in their lifetime. I see it as phase one, that we got this trial, we have this result. Now we're going to see whether or not it can actually be translated into practice and what you actually achieve for people, and whether we can learn who actually benefits and how we do the selection in ways that are going to be smart and wise, so we just don't apply it to everyone with AS. But we have ways to stratify risk and stratify the likelihood of response to each of the surgeries, so we can be smart about how we deploy this. And then we're also able to talk to patients in ways where we lay out trade-offs, risk benefits, and we really try to align it with their values and preferences so that with the recommendations. But I don't think in this country we're in any position to deny these kind of things right now. It's going to be a larger discussion, but one thing we can do is try to avoid using these techniques in people who aren't likely to benefit, and making sure we understand what we're achieving in real-world practice.
Yeah, these are all very good points. It seems to me that the magnificent thing about is that you can put a device percutaneously or apically, and I think that is a great achievement.
Proof of concept is
which
very important.
The concept years ago, I think none of us would have thought this would be possible. Clyde, give us a sense of what you think.
I'm going back to this notion that this is a game changer, but I think we have to understand what is the game involved here and what are the risks involved. I would hope that we don't have indication creep, definitely a significant breakthrough. But with the body of information we have now, we know that there is an ongoing risk of death, even with a successful procedure. Stroke affecting almost 1 out of every 10 who undergo this procedure. We've got concerns about vascular access and vascular complications. These are things that greatly impact morbidity in the lives of people that are already infirm because of age. So I think we have to understand what game is being changed here, play the rules very carefully, and remember that this is critical aortic stenosis. So that is a context in which we're discussing. Anything other than that needs to be studied as rigorously as this has been studied, and we ought to avoid indication creep. But we also ought to remember that we're looking at the pioneer devices. The subsequent devices that are coming along may benefit some of these concerns we have. So yes, it's a game changer, but we have to define the rules of this game very carefully because it's not a free and easy game.
Yeah, but the game that I'm referring to is that we've now moved from thinking of late-stage or advanced aortic stenosis from a surgical disease to the possibility of it being a percutaneously treated disease. And one of the things that we at least have to open our eyes and say is, wow, I mean, here's a technology that's made a huge step forward. Now, when I say that, I say, well, let's also take a step back and look at what they did in the trial. And some of the things that Laura brought up, I think, are really important. That here was, to me, as a clinical trialist, it's a beautiful clinical trial. I mean, they took this notion that you would take very ill patients, think about a highly advanced technology, and how would you apply that at multiple centers? This notion of the heart team or the care team that comes together and reviews cases, I think that's an advance to have done that in a clinical trial. Can we do that in clinical practice? Or are we going to see some diffusion of the technique that's different than what was done? And that's the topic I want to come back to.
I think it's a danger.
This is very interesting.
Yes.
Because there's a parallel here through the prism I use to see medicine, which is heart failure and heart transplantation. We've done trials like this in heart transplantation, looking at desperately ill patients and making decisions about the adequacy of devices. And in clinical practice now we use a team-based approach. But the other caveat that I think needs to be introduced here is that this is a choice. It's evident that our surgeons were able to perform in these higher risk patients admirably and receive very good results for these patients that otherwise would have caused us some pause. And so I think that is yet another bar to achieve, to have the community standard for surgery for those patients that have critical aortic stenosis meet what's in this trial.
Think about what we've seen this week. Partner, STICH, the mitral clip, all of which we're going to talk about. What underlies all of those? It's people thinking about what might be best for that patient, engaging the patients in that sort of, milieu of discussion. Harlan's written about this. In this case, we offered them randomization. But in the future, I think what's underlying all of these studies is what's best for the patient as opposed to what's best for me as an interventionalist or what's best for you as a surgeon. It's really changing the way we're going to think about this.
Society is going to demand on this.
Yeah. We have to.
There is no other way. On economic basis. Before, if you don't mind, I like to ask David very quietly. You are listening, and maybe you are going now to make a breakthrough in this discussion.
Well, it's easy to say I agree with everyone too, but just to understate the comments of the complexity of these patients and the procedure from an interventional perspective that Bob and Laura have highlighted, we often said that PARTNER wasn't a trial; it was a career. And there was a great amount of work into the evaluation of these patients that led them to even come to the operating suite or the catheterization laboratory. To highlight the comorbidities of these patients, too, keep in mind that as we offered this therapy, oftentimes in our own enthusiasm as surgeons and as interventionalists and as healthcare practitioners, that 1 out of every 4 patients was going to die by the end of the year. So there's clearly more room for opportunity. There is, to be sure, in Europe, Clyde, a creep, as we call it, a factor of treating less high-risk patients with lower STS or Euro scores. And I think this is something to be very, very careful of, as we still don't know about the durability of these valves and other technical issues. But I would finally just highlight one other issue that you raised briefly, is that this is a first-generation technology, and it's really a first-generation procedure. There are actually, PARTNER in many ways evaluated 3 therapies, didn't it? A transfemoral percutaneous procedure, a transapical procedure, which had variable to surgery, different outcomes, numerically at least lower mortality with a transfemoral approach, numerically higher outcomes with a transapical approach, and that might be an important consideration for a surgeon who now has 2 options available to him or her, but still may perhaps favor something that is more tried and true and more familiar to his or her practice. So when we think about, and the final comment I would just say is when we think about stroke, this can't be discounted, of course, because we know from patient self-assessed surveys, patients consider stroke perhaps sometimes feared more than mortality itself. And once again, there's a suggestion perhaps that the mechanisms of stroke between transapical and transfemoral are different, that perhaps this risk may be mitigated with improved technique, improved catheter technologies, perhaps distal embolic protection as well.
I have 2 main questions, maybe before we close the subject. The first one is this tendency to go into people that are less sick and younger people, which is, everybody was talking in the meeting. I want to be sure that there is a concern here, because it seems to me that the stroke issue, which became by MRI, was 70% of people already had the spots in the brain. Is very concerning. What I'm saying is this is a great trial, is a great advance, but you don't feel that we should be very, very cautious in moving the envelope to younger people, at least at this time. I'd just like to hear.
I think we've seen stroke oftentimes utilized as a significant concern in deciding between percutaneous and surgical coronary revascularization. Here, I think we should use it and leverage it in the same way to consider transcatheter versus surgical.
Well, I think what's really critical is, and I think a few of us have mentioned this, and I think we all agree, that patients may perceive these different risks differently. And this is a trial, it was a non-inferiority study, where the mortality rates were essentially the same. So we can't say that this is a technology that should replace surgery in the population that was studied. Rather, we can say we know more now from the randomized trial about how we can explain the procedure to patients and how they might be able to make choices. Now they can understand that better.
So as you know, I'm a great proponent. Bob's mentioned, really presenting it to the patient. But in presenting to the patient, I have a hard time being an advocate for the early use, because I know what I can expect with surgery, and and now I've got something new that's going to roll out that I can't be assured is going to get the same result that it did in the trial, especially at a place that's just going to be starting out. And I'm a little worried about how are we going to gain that experience, and are patients really going to be adequately informed about it? Because it wasn't like the trial showed me much better results. Now, I know that a certain patient may favor it because of the trade-offs, But in a situation where there wasn't a slam dunk advantage, it's close. So in a close, under the idealized lights of the clinical trial, what's going to happen the first year when people start getting the hybrid labs and do it? Now, if I went to a place that was doing the trial, I might feel better, but I'm a little worried about a place that says, this is your case 2, your case 3. And I don't know how we're going to do that. What is the training going to be involved? How much time is someone going to spend at one of the partner sites before you're going to graduate them and say you're ready to do it? And these are things which concern me a little bit. I don't know. Some of you might have some thoughts on that.
Well, it's not just one person going to a training site. It's the team concept. The team has to be put together. So that's a major investment. But the one difference from what you just stated, Harlan, is that clearly in the truly inoperable patient with critical aortic stenosis, I would have no difficulty today getting that patient to a site that does this.
Yeah, I'm talking about the trial that we just saw.
There are two different types of patients.
Partner A.
You have a comment.
I mean, I just some sort of information from Europe where we've not had a randomized trial, but much larger volumes of experience. I think the concern that's been raised is the diffusion into a low-risk population, and that is undoubtedly happening in some European countries. It may or may not be related, but in the last year, the countries that have seen in where that has happened have seen an increase in the early mortality following the procedure. So I think that's an important observation to make. I think it's absolutely key that the team ethic is maintained. In Europe, the teams were trained sort of didactically, then with going to units, and then proctors would come. And I think I would recommend that that's the way that all centres in the US are trained. And I think the final sort of comment from Europe, because I think it doesn't get mentioned over this side of the Atlantic too often, is I think there are other access routes for TAVI which may also mitigate against some of the complications that we've seen. And I think that the subclavian and direct aortic routes offer different approaches for different patient populations to minimize risk. So that's just maybe a little flavor from a TAVI and a different...
complication rates in practice in Europe compared to what was presented in the trial?
The trial is very similar if you look at it to what has been seen in all of the European national registries in terms of I think the early mortality, 30-day mortality in the trial was a little less, but the 1-year mortality is almost the same as in the registries. The vascular complication rate, the 30-day stroke risk. It's incredible how comparable all of these registries and now the trials are. I think one of the big concerns, which was alluded to before, is this attrition between 30 days and 1 year, which is very well demonstrated in the TAVI arm of cohort A, where the mortality is 5% at 30 days and 22% at a year. And it's absolutely key that we try to understand who those patients are.
I mean, we are going to have educational programming for people who want to get involved with this, for health systems that want to get involved in this. And we are going to absolutely have to have some system of measurement to be able to understand. What I worry about, contrast to Europe, Europe largely practices a regionalization of care, of high technology-oriented hospitals who offer high technology care. In the U.S., we've not had the appetite so far to tell people, no, you shouldn't be doing that. That should all be done over here. We're going to have some issues because my sense is if you don't do this in big centers with dedicated teams, there may well be problems.
It was all registering, isn't it? All the countries in Europe are all registering because
most
I think
this
is critical.
Germany, France, the UK all have
because I can
large
see,
registries.
I can see when the teams are not integrated, I can see the problems. I mean, it's obvious that...
I just totally support what Bob says. I think that this should be done in big specialist centres for the foreseeable future.
But perhaps as a final comment too, Harlan, is that maybe to look at the other side of the page on this story is that this did represent the learning curve in many ways for us. We didn't have a great experience going into this, and with roll-in phase, this really was the early phase of experience. And so I'm hopeful that our expectations should be this would only improve.
Did you find any difference in the mortality and the complication rates between the center's early experience versus their later experience?
I can't quantify that, but qualitatively through best practice sharing amongst the investigators, which occurred on a very diligent basis throughout this trial, the answer is unequivocally yes, especially with regard to the vascular complications and technique.
Harlan, I had a final question for you. It's a conceptual one, but I'd like to know how, when we talk about cost effectiveness and, $50,000 per year, now, in the way society works, it should not be different for that the person who is effective in society versus, this is a very tough question, but we are open here, and it's very important because we are going to be dealing with a population. The average age is 84 years of age. I don't think cost effectiveness has the same connotation than if you have in a younger population. Don't be afraid to say what you think.
Well, the denominators are usually a year of life saved or can be quality-adjusted life years. Look, this is a bigger question, and it's a slippery slope, and we just don't know how can you begin to value someone's life and make those kinds of decisions. Society as a whole is going to need to grapple with this issue. I mean, I was impressed in the Wall Street Journal when they showed that there are at least 10 states in the country who are spending more than 1/3 of their budgets on Medicaid. 1/3, that's not their whole health budget. That's just on Medicaid. And we're going to have to figure out where the waste is in the system and where we're doing things that aren't effective. And then if we've done all of that and we're left with the effective things and we can't afford it, well, the society is going to have a discussion about where that money can go. But I worry about judging, even for any purpose, that someone's life is more valuable than others. Now, we may decide to concentrate on prevention. We may decide to concentrate on kids. I mean, there's lots of ways that we may be able to concentrate. Sure. But I think it's a very tough discussion.
Thank you. Well, what we are going to do is we'll move now into the second type of procedure, the percutaneous repair or surgery for mitral regurgitation. This is actually has been a discussion for a few years with a lot of skepticism at the beginning, and now I think skepticism has moved into maybe curiosity, if we have to put a word. This is a very interesting study. Basically, is a study. Laura, in the paper that came out in the New England Journal, you are the senior author of the paper, so I'm sure you have a lot to say. Maybe you should not say anything. Allow us to
I'll listen first.
Yeah. Anyway, 37 study centers in the United States and Canada participated in the study. The acquisition was between September 2005 and 2008. These were patients with very severe chronic mitral regurgitation, grade 3 to 4. The patients had a low ejection fraction, in general less than 35%. And the primary regurgitation should be central, I believe, with malcoaptation of the middle scallops of the anterior and posterior leaflet, just to be able to put a clip appropriately. Well, anyway, this is the setup. 279 patients were actually entered into a randomization of 2-to-1 ratio. The 2 is for the percutaneous repair, and the 1 is for conventional surgery, repair or replacement. And that is basically, you will explain to us, this is the procedure, is the clipping of 2 leaflets of the mitral valve. The primary endpoint, composite endpoint for efficacy, was freedom from death from surgery for mitral dysfunction and from grade 3-4 mitral regurgitation at 12 months. So all the things that we don't like to happen. And the primary safety endpoint was a composite of measured adverse events within 30 days. Well, here are the results. At 12 months, the rates of the primary endpoint for efficacy were 55% in the percutaneous repair group and 73% in the surgical group. So certainly the winner is the surgical group. Then, looking at the stratification of the different groups, we have surgical intervention that is needed in 20% of the patients who enter into the non-surgical group. So there's a significant crossover. And this is actually very important because 20% of the patients in which non-surgery was performed as a primary or as a crossover still are left with significant mitral regurgitation. So we really have about 40% of patients who either they require intervention with surgery of the group that were treated with the clipping, and the other 20% were left with significant mitral regurgitation. What is interesting, and one has to go into the details of the study, but what is interesting is at the very end, even with class or grade 3 or 4 mitral regurgitation appears, the patients apparently felt better. And when you compare both groups at the very end, this is intention to treat, so some have surgery as a crossover, and this was good. They did very well. They did exactly the same clinically at 12 months of follow-up, and now it's about 1 year of follow-up. I just want to summarize by saying that the percutaneous repair was less effective at reducing mitral regurgitation, and was associated with superior safety and similar improvements in clinical outcomes. The safety, however, had to do with blood transfusions. That is, the surgical group required much more significant blood transfusion than the non-surgical group. So the study is an interesting one. Certainly is looking at feasibility. One question I want to ask Laura before we go into more details: why a year ago the results were presented somewhat differently? In other words, we were here and we discussed them, and the results were very similar in every aspect. What has changed in terms of analyzing the data here?
It's a very good question. So I think the most important feature of the design is just as the studies that we have talked about comparing a percutaneous aortic valve versus a surgical approach. This is a randomized trial, and I think that's the most key part of the design, is that we have the randomization and the level of follow-up that was obtained in the study, having core laboratories to assess mitral regurgitation, for example. What's changed in the presentation of the results, initially there was a great interest, I think, in looking at the per protocol of those patients who did well following the procedure to see what was the effect of the device. I think you've heard during this course of this meeting advocates who are proceduralists, such as surgeons, commenting on the percutaneous valve trials. Well, why not look at either the as-treated population or the patients who actually got the device or surgery? And that gives you some information about how patients do in the long run, in the long-term follow-up, once they have a successful procedure. That being said, I think as a trialist that the most important question is, how do we choose between two different treatment strategies? And how do we discuss those options with patients? And so from a trialist perspective as well as a clinician's perspective, the intention to treat, to me, makes the most sense as a way to present options to patients. And so the primary analysis that you see presented in the New England Journal, as well as by Ted Feldman in the Late Breakers, was an intention to treat strategy, because that lays out, if you are assigned to surgery versus the percutaneous therapy, what is the rate of mortality, what is the rate of mitral regurgitation, and what is the rate of you needing to have a repeat surgical procedure. What we saw was that the rate of mortality was the same. The rate of mitral regurgitation was higher in the percutaneous arm, and about 20% of patients required a surgical intervention after the percutaneous treatment in the first year, and then 22% in the second year.
It's important you didn't mention mortality was the same. I'd like to ask you, Neil, should we be putting 3 clips in 1 ring? This is a technical issue here, it seems to me, because the main problem was the residual mitral regurgitation. So I'd like you to give us a sense, and maybe Laura, you can also mention, and maybe you can tell us how this technology is going to change, because obviously it needs a change.
I mean, I think this really is very, very first generation technology. and I think the results are very encouraging at that stage. Certainly in the European experience, very many patients are getting 2 clips. I'm not sure from the trial how many patients got 1 and how many got more than 1 clip.
This was one example of, as David mentioned, with these new devices, there's a learning curve. So during the course of the trial, it became possible to allow investigators to place 2 clips. And that is a useful addition to the treatment strategy.
I think that you alluded to really Alfieri's work showing that the concept behind this, the Alfieri stitch, really only got good clinical results when there was a ring annuloplasty applied to it. So one might discuss that the future is a MitraClip plus a coronary sinus device. But actually our experience has been that I think it is possible that the MitraClip is doing something at a ventricular level. If you look at TOE and you look at the position of the papillary muscles, the clip gets enough leaflet in that it actually starts to bring the papillary muscles a little bit more back into plane, particularly in the functional patients, and a little bit more basally. Now, it's something that ourselves and some units are looking at, but it may be that the MitraClip is doing something a little bit beyond just at a leaflet level. But going back to the trial, I think Clyde said partner A was phase 1. I mean, this I think is pre-phase 1. I mean, I think this is a very small trial. There's less than 100 patients in the surgical arm. There's a mixed bag of patients with functional degenerative. And I think what this shows really is no more than the clip can have an effect. And I think much more detailed studies dividing patients into functional and degenerative in the setting of trials is what is needed to evaluate this technology further. David?
So to be sure, there are also, just as in the aortic valve technology space, a number of additional technologies, edge-to-edge repair, transcoronary sinus technologies too. For me, in the EVEREST II trial, though, it's important to keep in mind that unlike the aortic valve trials, these patients are eligible for both therapies, and they're not they're highly selected and not necessarily high-risk patients, which is appropriate, I think, in this case. This may be a very appropriate and perhaps considered first-line therapy for very high-risk patients, which is a point of additional study outside the scope of this context. Keep in mind, too, that in this trial, when patients had a suitable result through 2 years of follow-up, there was a durable outcome. But most importantly, this is a technology that doesn't exclude the potential for downstream surgical repair. And so I think that we work in this construct of this or that, of surgery PCI, of surgical valve repair, transcatheter valve repair. This is unique, and I think for that reason alone, it was very uniquely suitable to present as an intent to treat, but then previously as per protocol, because it's really, it's not testing exclusionary therapies, it's testing strategy. Would you go with this result first? And if it were successful, we can share with you a high likelihood of durability. And if not, then you can go on for surgical repair. So I see it as not competing, but rather as alternative strategies.
I have a difficulty, however. This is mitral regurgitation. It's a volume overload condition. These patients have pulmonary hypertension. I'm not sure the 2-stage approach here is like in other conditions. For example, in aortic stenosis, you can prepare the left ventricle by doing a valvuloplasty and then going to surgery. But in a volume overload condition, putting a clip, I'm not entirely sure how far you can go and say, well, and then eventually you increase the risk every time you do a procedure. I take your point, and I think it's an important one, but it's just, I have some difficulties.
The longer-term follow-up and the follow-up of some of the ventricular dimensions are really critically important. As you were mentioning, the MitraClip does appear to have an effect in improving ventricular function as well as improving ventricular dimensions. And this is not a given, because we knew going in that it could be less effective at reducing mitral regurgitation. So there could have been a concern that the ventricle would have enlarged over time, for example, but that wasn't the case. They actually did improve.
Isn't there an issue here that I've been trying to understand in seeing these data? Because I agree that we have to figure out both how to study strategy as well as to analyze strategy, but how to offer it clinically. One of the things that I don't want to say troubled me, but at least wanted me to raise questions about EVEREST was in those patients who went on to operation, a sizable portion of them now got valve replacements. Although at the outset of the trial, to get into the trial, you had to be valve repair eligible. And there's a big difference between getting your valve replaced and your valve repaired. And a strategy would be okay if the patient's not, and we're going to come to this in STICH, if the patient's not giving anything up for the subsequent procedure. But if I'm giving up the possibility of having a repair.
Great point.
But wasn't that part of the issue in this?
Well, I think that is a good question, because there was a higher rate of replacement when patients went to surgery after the clip. But if you think about it, and actually as we've looked at it, those patients who were not going to get a good result with clip and didn't get a good result with clip were probably the same patients who would require replacement. So they tend to be the more complex patients with more complex leaflet pathology.
But another reason to say that this thing needs a lot more work in terms of study.
Well, I don't know about that, because it may have to do more with the patient population and figuring out, not so much doing another trial of a larger size, but figuring out which patient population most likely is to benefit from the device. That is, where is the treatment gap in terms of efficacy the most narrow between the percutaneous procedure and surgery? And so far, they're exploratory, really, because they're secondary analyses. What we've seen are the older the patients are, the more functional MR they have. That is, it's not mediated by primary leaflet pathology. The closer those results are to the surgical outcomes. And really, it was that patient population that you can speak to as a surgeon is more challenging for us to deal with surgically, the functional mitral regurgitation.
Interesting.
So that's an important population that we saw more benefit.
I agree with Laura. I think the functional mitral regurgitation population is really the population to be looking at with this technology. I would like to come back to, though, the idea that it's a no-lose situation to have a go with the clip and then go to surgery. In the trial, the repair rate is about 50%. In my other life outside transcatheter valves, I'm a mitral valve surgeon, and myself and my colleagues in Europe are now seeing these patients coming back for surgery. It is very, very difficult to repair these valves, particularly if the clip's been in for a while. It's embedded in the leaflet. You have to cut bits of the leaflet away, reconstitute the leaflet. It is not the same. It is not a no-lose situation for the patient. I think that's very important. It's fantastic technology. It will get better. It will develop. But at the moment, we shouldn't be saying it's a no-lose situation to the patient.
It may be that we need those larger experiences. I mean, this is one area where the registries that we see coming from Europe, or the monitoring of devices in use is such an important area, so we can get larger numbers of patients to be able to see what the true repairability is of these valves and what predicts that.
Clyde?
Unlike the discussion about TAVI, where I'm convinced there's some very clear benefits there, I'm completely at equipoise on the mitral valve clip procedures. And I feel that way because each year, 2 years of data now, a significant number of patients have to undergo surgery in addition to the caveats that you're discussing now. One wonders, why not have a primary surgical approach? Because it has traditionally been a surgical disease. And we also know, as clinicians, how much we wrestle with the decision of when do you send significant mitral insufficiency to the operating room. We're looking at volumes and dimensions, and now we have a procedure that might have some patients getting a procedure unnecessarily. So I'm completely at equipoise on this.
I think this is the difference between the aortic valve and the mitral. In the aortic valve, do you beat the surgery and you can go earlier and earlier? Here is the patient has to be treated medically. There's no other option. Then this could come into the functional low ejection fractures and so forth. I see two completely different scenarios, at least at this time.
I agree.
Yes, Harlan.
Clyde, there was only one patient, in terms of who needs surgery after a year, in both of the treatment arms. Just to clarify, there was only one patient in each treatment arm that subsequently needed surgery. Granted, we want to continue to follow patients for longer and see if more patients require surgery, but it was a small number.
I found myself wondering in this trial what would have happened if you'd had an arm that was medically treated. It made me reflect on how little evidence we have about in 2011, given our current approaches to these patients, about what their trajectories are and their ability to really stratify risk and to know who's really going to go quickly. And And just to your point, Clyde, I think it's really a good one. We're struggling with it. We're trying to make inferences. Are we going the right time? The repairs sort of brought us earlier and thought, well, maybe we should jump in. But I think more than anything, I was thinking about the patient selection and the real need for us to gather some evidence and understand better exactly what risk strata they're in, because you guys went by the guidelines. That was the right thing to do. But as I reflect on the guidelines, they really aren't based on good contemporary data that help us make the right decisions. And we have a lot of information coming at us, but we have a hard time knowing exactly if a patient says, what can I expect in the next year if I'm just continuing to be treated medically? We're at a shortage of good information.
Harlan, in other words, are you saying that what is really needed now is a longitudinal follow-up of medically treated patients that cannot undergo what we have, which is the surgical intervention, and to do the clipping and see how they do compare with the medical therapy, like the group B of the aortic valve?
Yeah, I think that we could be, especially on the margins. I'm not convinced in this day and age that those patients couldn't be watched carefully over time and see what their trajectories are. Maybe we're studying them a little more often, but anyway, I think that's the kind of information that we could use. And
I think it's interesting, though, an observation from this trial, like others, if we did a cohort B-like study, it would be that something Bob raised earlier, we're taking out the element of asking the patient what the patient wants. And it's striking that in the surgical arm of this trial, about 15 patients, I think, who were assigned and eligible for surgery ended up not participating in the trial because they were hoping that the coin would have flipped the other way for them and they would have had what they perceive as a less invasive procedure.
But let me be clear, I know this is what Val was saying, but I'm thinking about, so if you think about this as an intervention, I'm saying there could have been a third arm. I think there are people in that group who would have done well at a year without either intervention. And we need to get smarter about who are those patients, how can we select them. So ones that we are sending for interventions where we have a pretty good confidence that it's a good decision.
It's a difficult disease, mitral regurgitation. You have the myocardial factor, you have the valve, which are all different types, functional, non-functional.
And you have the inter-rater and intra-rater reliability of even assessing mitral regurgitation, whether it's by echo or however you're doing ventriculograms, so that, in our echo lab, we try to quantify, but I'm often not confident that case to case we're doing a great job.
That's why it's such a challenge to know what the standard of care should be, because, as you said, it's a moving target, and the surgical studies that we have are not. We don't necessarily have control arms, and we'd like to have better data.
Okay, let's put a stitch into the discussion.
Go from clip to stitch.
Yeah, from clip to stitch. Yeah. Well, the STICH. You remember the STICH study? This was last year when it was presented, and basically, this is a group of investigators that decided to study coronary artery disease with low ejection fraction. And there were three strategies. In one group, included patients who were eligible for either medical therapy or CABG plus medical therapy, but for nothing else. There was another group that were eligible for medical therapy versus resection or remodeling of the left ventricle that has an akinetic zone. And then there was a third group that had everything, could be treated medically, could be treated with bypass, or could be treated with the resection. And so from these three different strategies, the studies are coming out, and there is a hypothesis, I guess 1 and hypothesis 2. Now, the hypothesis 2 was presented last year, and that is the use of bypass surgery with resection of the akinetic, dyskinetic zone actually was not better than bypass surgery alone. Okay, that was one issue. Now we have here two papers which are interesting. They just came out and were presented here in this meeting. And the first one is by Dr. Eric Velasquez, I think is in your group at Duke. And basically, the question is the role of coronary artery bypass grafting in the treatment of patients with coronary artery disease and heart failure. And in this case is a specific randomization, which is bypass versus medical therapy. As simple as that. So there were over 1,200 patients with an ejection fraction that was 35% or less, coronary artery disease, and they were amenable to CABG or to medical therapy, and they follow one procedure versus the other. And the primary outcome was the rate of death from any cause after 12 months, I believe. And then the secondary endpoints were the combination of death from cardiovascular causes, death from any cause, or hospitalization for cardiovascular causes. So the first one is, the primary endpoint is a generic one in terms of death. So here are the results. The primary outcome, which was mortality of whatever cause, was 41% in the medical therapy group. These are patients with low ejection fraction, and 36% in the CABG. This was not statistical significant. What was statistical significant is the secondary endpoints when the events were cardiovascular. The death was cardiovascular and the hospitalization was cardiovascular. And here we are. The conclusions in this randomized trial, there was no significant difference between medical therapy alone and medical therapy plus CABG with respect to the primary endpoint of death from any cause. But patients assigned to CABG as compared with those assigned to medical therapy alone had lower rates of death from cardiovascular causes and death from any cause or hospitalization for cardiovascular causes. Well, my friends, what do you do with your patient who has a low ejection fraction, has coronary artery disease, and obviously is not severe ischemia, otherwise you may intervene, although we'll come into this in a moment. What do you do in view of the trial? A primary endpoint doesn't take into account specifically cardiovascular. The secondary endpoint it does. And this is the question, Robert.
Well, I mean, STICH to me is a great example of a number of things that require reflection.
First, I am reflecting for the last 24 hours.
You know, first of all, this is a question. This is one of the central tenets of cardiology going back 30 plus years, that if you have multivessel coronary disease and a low ejection fraction, you get benefit preferentially from revascularization. And as many of you remember, getting this trial done, getting surgeons and cardiologists to agree to randomize their patients to this question was exceedingly difficult. And so the first thing this says to me is, open up your mind when there's a question and think about, do you have equipoise, or are you too wedded to what you do to not accept that there might be equipoise? That's point one. Point two is that this is one of the challenges of these strategy trials. So if you look at the overall results, it's not a negative trial, right, Harlan? It's a neutral result. It did not show that one therapy was superior to the other. But peel that back. Look at the per protocol. Look at the treated. Look at the secondary endpoints. There's something here. And I think what this does, Val, is this is the perfect construct to say, have a conversation with your patient, lay out the opportunities. Here's where I think they have very good data that says the patient doesn't lose by waiting if they want to think about it. Yeah. And they showed those analyses.
Yeah, excellent. Harlan, how do you interpret these? How would you act?
I grew up where, we're going to get to the viability study too, but I mean, this was a central tenet, or, sending people for viability studies. It makes me wonder, when we do the studies and they don't show superiority of a more intensive, somewhat dangerous, expensive methodology, are we going to say to people, carry on? Carry on. It's okay. Because if you squint a little bit and look to the side and you turn your head and you do a bunch of comparisons, there's a couple things that make you look interesting. And it's plausible. It's ultimately plausible. So do you say to a patient, and how do you frame it? And how do you tell them? Because you're not talking about, this group's walking once around the park and this group's walking twice around the park to get a little extra exercise. You're talking about a group that you're sending for open heart surgery. And how are we going to disclose it? And on one hand, we don't become prisoners of a single trial. On the other hand, what are we going to demand in this day and age when we are under a lot of pressure to allocate our resources where we know we're going to get some return? And, I get back to, we always are showing average results in these trials, and what we're trying to understand is who are the responders, who could benefit from this, but then what do we got to do to test that? And I just wonder, we just finished the study looking at fibrates, where we said 2 negative fibrate studies, and in the U.S. fibrate, prescriptions are going up like this. And people are, we didn't take, I'm not saying take fibrates off the market, fenfibrate, but what what are we going to do with the evidence when it comes out this way? And I think it's a central challenge to us. Do you leave it on the table, push it to the patient, or you say, I don't know, where is it going to be in the guidelines now? Is it a 2B? Or
it's not a 1A.
It's not a 1A.
Clyde, what is your opinion?
I don't think we have to wrestle that much. I think this is exactly the result we would have wanted, because it restores the element of choice and decision-making at the bedside, at the table side with your patient. Imagine if it would have been very clear that surgery really had to be done. Now you have a very difficult space to navigate. You're telling people you really need to have this operation. It may not be their preference. Their operative risk may be higher. Your surgeon's anxiety about that case could be different. Or, on the other hand, you say, well, medical therapy prevailed and we just don't do this anymore. Well, it's just not that perfect to say.
I totally disagree with you, by the way.
Well, but just a minute. The idea is that you can sit down and you can comfortably say that on a well-constructed medical regimen, and that's key, patients in this trial were treated very nicely and according to standard. So on a well-constructed medical regimen, that is an acceptable alternative, and the patient can be followed until such time that you change your mind and you go in a different direction. Conversely, a patient can be operated on safely. So I firmly believe that this establishes the benefit of choice and improves decision-making.
I used to send these patients to viability studies. And now it comes, I see the same that paper, Robert Bono, the study, they did viability, and at least as I read it, it didn't serve any purpose because all the other variables were more important in predicting, but not the variability, either for surgery or for medical therapy. So we have to close the shop, Robert.
Well, I just want to respond one thing to Clyde, just because I feel the need to say this. So I agree with you. By the way, I told you I grew up on viability studies. Everyone said get viability. I was at Yale, of course, the Center of Nuclear Cardiology. But here, I don't think you need a trial with a close finding in order to embrace shared decision making. I mean, even the positive trials are showing you an advantage on average in patients' preferences. They don't have to follow the direction of lowering the most risk. I mean, I say, not everyone's driving Volvos. If those are the safest cars, we let people drive cars that are not as safe, and it's up to us to embrace shared decision making no matter what the result. The question I have is when you have an expensive procedure that's failing to show that it's beneficial, can society say it's up to you if you want it, even though we can't have the data to show that it's beneficial? And I think that's the bigger question I have.
But I think we're in the same place because I agree shared decision-making ought to be a tenet of medicine. But remember the context here. Many practitioners had already assumed that it was correct to send patients with very low EFs to the operating room with multivessel disease without evidence to really support that. And now with these data in hand, we can arguably sit down and have a discussion and talk about these are your options and these are the expectations. I do think this is an outcome that is acceptable.
So, Harlan, how do you interpret the secondary analyses of CV death, hospitalization, the composites, and how would you interpret the evidence of if you actually have bypass surgery, a highly significant benefit in favor of bypass surgery? I mean, it seems to me that this isn't one of these ones, everybody sort of did the same. When you peel back from the primary result, there does seem to be something there.
Laura, you feel like you want to say something?
Well, I think there are some problems with taking a step back and saying, let's just look at the people who actually had surgery. We've been talking about the challenges of having these types of randomized trials where you have patients who vote with their feet and they get randomized to something and then they don't follow through with that treatment. And that certainly happened in this trial as well. So you do have some bias that's introduced when you eliminate those patients from the
David
study.
is going to put the ice.
Well, I'm still waiting for the Volvo randomized trial, but until that one happens, I have to really support Clyde's comments that the question really is are these results going to change our practice? And in one way, I don't think they're going to change our practice, but I think they're going to reinforce the decisions we make already. In other words, we have to remember in clinical practice, we individualize the decisions for surgical revascularization routinely. And I think this would provide us the rationale to make that decision for one patient, to treat that patient medically, and the other to refer to surgery. And then we forget about percutaneous revascularization altogether, which is commonly occurring, and how that might fit in for these patients.
God, this is a very human kind of a commission here. All of you are talking about patient relationships and forget about trials, guidelines, and everything. I mean, it's quite of an impressive turn.
I do wonder what if we were to insist that and I'm not suggesting this comes off. I mean, part of this is just playing this out with the evidence, but I'm just wondering if we were to sit around and say, what should every patient who's contemplating this decision know? What should they be exposed to as basic facts that we can all agree on? And then go, to more individualized discussion. I think that's kind of interesting to me, because you could frame this trial, as you have suggested, in a lot of different ways.
Yeah. And we've already heard that.
And I think there may be some centers that are still going to be 100% going one way, and some that are going to be much less the others. And are patients going to be disclosed that we're the type of center that's doing this or we're the type of center doing that?
Yeah, my concern is that these results are, I don't think they are going to change practice. I'm afraid that each person is going to continue to advise their patients the same way that they have been. Right,
exactly.
Right, and actually the viability study is something that's more earth-shattering or groundbreaking in terms of making us take a step back and think about how should we do things differently.
Boy, but doesn't it also tell you, though, that I can tell you from having been involved as part of the group that did the trial, not personally involved with it, the challenge of getting doctors to do this kind of trial is extraordinary, and this trial needed to be 3 times as big.
But if you talk about, by the way, the negative part and the viability, I wonder how many dollars have been spent on viability studies in the last decade. This study, if it can prevent that in the future, that's a big...
I think it's a bigger step, yeah.
Well, I think I would agree with Clyde. I think this is important, and as a surgeon, I think it helps the surgeons make decisions on these patients, because what it's saying is that medical therapy is a very reasonable option.
Good medical therapy.
Good medical therapy. And when we as surgeons look at these patients, I'm sure you do, there are patients that you see who are morbidly obese and their renal function's not so good and their targets are not very good, and you know that the risk in those patients is very different to the guy who looks quite fit, very tight proximal stenosis, great big distal vessels. And I think it allows us to maintain some individual decision making along with the patient.
But the risk of both therapies, both strategies are going to be different for both those 2 patients you said. So it's not just whether it's easier surgically, but the medical therapy is going to be different.
Well, that's a key thing in this trial.
Excuse me, I have to really, I have to really stop this, and maybe we can have a beer in a few minutes and discuss
Absolutely.
it. Just we can give a summary for the people writing guidelines from this committee. But basically what I heard is that in the partners trial with the catheter aortic valve replacement, we are giving a word of caution in not moving too fast to younger people and healthier people, because there are a number of problems that have to be solved before we jump there. In terms of economics, I quote my friend here, and that is complicated. Let's leave it. In terms of the percutaneous repair, I heard that we have to follow this procedure longitudinally, and I think this is a good point. I am not sure it's stated for trials. We still don't know enough, and maybe new technology will evolve, and perhaps we will change gears then. And then we go into the STICH trial, the patients with cardiac failure and coronary artery disease. And I think that, might not change practice, but certainly the viability study that was negative, I think this is going to make a difference, because it's a lot of money involved in trying to look at that aspect. I think we have to study that carefully, though. I mean, I didn't have a chance to digest all of this, because I always thought, at least based on what is coming out with MRI, for example, which is one of my interests, I thought the viability aspect was important. I like to see how this was done before we say this is a close. I don't know if you want to say more. They say no. I stop. Fine. So thank you very much to everybody. You're a tremendous human group, Sometimes it's like too human. But anyway, I really appreciate you being here today again, and to you who have been watching until this last minute, thank you very much. And we'll meet again in the next meeting, the European Society of Cardiology. Thank you.